So next is, we have here another actual nursing care plan. So for the assessment cues, we only have objectives. So chest pain, tachypnea, jugular vein distension, and vital signs, which is pulse rate is 110 beats per minute, blood pressure is 105/65 millimeter of mercury, and 78 MAP. And we also have here the respiratory rate, which is 24 cycles per minute. So for the nursing diagnosis, decreased cardiac output related to impaired left ventricular contractility as evidenced by chest pain, tachypnea, jugular vein distension, and vital signs, which is the pulse rate 110 beats per minute, the blood pressure 105/65 millimeter per mercury, and MAP 78, and the respiratory rate, which is the 24 cycles per minute. So for the objectives, within my 2 hour span of care, the client will be able to relieve from chest pain, maintain adequate cardiac output as evidenced by pulse rate 110 beats per minute, BP 105/65 millimeter of mercury, and respiratory rate 24 cycles per minute.
Next is the nursing intervention. For the independent intervention is, first assess the heart rate and blood pressure, because sinus tachycardia and increased arterial blood pressure are seen in the early stages. BP drops as the condition deteriorates. Second is assess the peripheral pulses. Pulses are weak and with reduced cardiac output. Third is assess for the client for chest pain. It indicates an imbalance between oxygen supply and demand. Fourth, assess the cardiac rate, rhythm, and electrocardiogram or the ECG. The 12-lead ECG may provide evidence of myocardial ischemia or the ST segment and T-wave changes or the pericardial tamponade or decreased voltage of QRS complex. Fifth is place the patient to semi-Fowler's position. This is to help the patient ease his breathing. Sixth is encourage the client to relaxation techniques such as deep breathing as breathing exercise. This is to reduce anxiety and conserve energy. And for the collaborative intervention is administer medication as prescribed by the physician, noting the response and watching for side effects and toxicity. It's depending on the etiological factors, and common medication include digitalis therapy, vasodilator therapy, antidysurrhythmics, ACE inhibitors, and inotropic agents. Next is administer humidified oxygen as ordered. The failing heart may not be able to respond to increased oxygen demands. Third is measure the height of the bulge or distension of the jugular vein. Ask the patient to lie down on the exam table with the head at 45 degrees. So the physician will measure the height of the bulge of JVD to indicate the CVP. And lastly is maintain the hemodynamic parameters at prescribed levels. For the patient in the acute setting, close monitoring of these parameters guide titration of fluids and medication. And for the evaluation, after my 2-hour span of care, the client was able to, first is relieve from chest pain. Second is maintain adequate cardiac output as evidenced by strong peripheral pulses, heart rate of 60 to 100 beats per minute within the regular rhythm, and the systolic BP within 20 millimeter of mercury of baseline. Next is the prognosis. It refers to determining the predicted or probable level of improvement and function, and the amount of time needed to reach the level of improvement in a health condition. There are 7 criteria in prognosis, and these are the onset of illness, duration of illness, precipitating factors, mood and affect, attitude and willingness to take medication and treatment, depressive features, and lastly, the family factors. First criteria is the onset of illness. We categorize it to good, which is 3, because the client was treated medically and underwent a cardiac catheterization, and the catheterization findings are diffuse coronary disease, but no other focal lesion was identified. He was admitted to the intermediate cardiac care floor for observation. So there are medications specifically to treat her current illness, and these are the aspirin, hydrochlorothiazide, and the ibuprofen for his osteoarthritis. Next criteria is the duration of illness. We categorize it to fair, which is 2, because the client has a past medical history of hypertension and hyperlipidemia and was admitted with dyspnea on exertion and chest pain worsening over 6 months. The client smoked occasionally cigars as a young man, but he quit 40 years ago, and he also intakes alcoholic beverages at 1 to 2 drinks per day. Next is the precipitating factors, and we categorize it to fair, which is 2, because the precipitating factors engaged by the client are high blood pressure and hyperlipidemia with dyspnea and chest pain. Next criteria is the mood and affect. We categorize it to poor, which is 1, because upon arriving at the client and upon the observation of the doctor, the client is confused and emotionally distressed. Next criteria is the attitude and willingness to take medication and treatment. We categorize it to poor also because the client is oriented to person but not oriented to time and place. He also states that the healthcare provider is the intruder in his home, and during the examination he is inattentive, and he is positive to CAM or the confusion assessment method due to inattention and disorganized thinking. Also, the client is not cooperating well in the treatment procedure because the client does not like to see his primary provider and often has avoidant health behaviors as noted by his spouse. Next criteria is the depressive features. We categorize it to good, which is 3, because the client is not experiencing depression. And lastly is the family support. We categorize it to fair, which is 2, because the client was accompanied by his son and currently living with his wife. And for the interpretation, the highest score rate of the client's prognosis is 42.86%, which is fair category. Because the duration of the illness of the client is fair, the precipitating factor of the client engaged is high blood pressure, hyperlipidemia with dyspnea and chest pain. And the family support is also fair because he accompanied by his son and currently living with his wife. The onset and the duration of the illness of the client are fair. While on the other hand, the 28.57% is both the good and the poor categories. In the good category, the onset of illness is good because his disease is immediately diagnosed. In depressive features, the client is not experiencing depression. In the poor category, the mood and affect are poor because the client is confused and in emotional distress. And the attitude and the willingness to take medication and treatment are also poor because the client is not oriented to time and place. He also states that the healthcare provider is intruders in his home, and during the examination he is inattentive and positive to CAM due to inattention and disorganized thinking. Also, the client is not cooperating well in the treatment procedure because the client does not like to see his primary provider and often has avoidant health behaviors as noted by his spouse. And overall, there is a total of 100%.
So next is the evidence-based nursing practice, which is about management of cardiogenic shock complicating acute myocardial infarction. So in the absence of intravascular hypovolemia, cardiogenic shock is a condition where there is a decreased cardiac output and end organ hypoperfusion. So cardiogenic shock is a medical emergency, so clinical results may be impacted by a high index of suspicion, quick diagnosis, and fast start of therapy, including transferring patients to a tertiary cardiac centers. So additionally, cardiogenic shock might appear at any point during the patient's sickness, usually soon after admission to the hospital. So the electrocardiographic alterations of myocardial infarction with symptoms of cardiogenic shock and the history of chest discomfort will corroborate the diagnosis. So the mortality rate for patients who present with an acute myocardial infarction complicated by cardiogenic shock has remained extremely high, and there are few effective treatments available. So this is true despite improvements in percutaneous coronary interventions and their widespread use. So many of the commonly utilized methods in treating these people are supported by scant data. So in this article, we include general information about cardiogenic shock complicating myocardial infarction, as well as an update on the current range of treatment choices such as inotropes and vasopressors, coronary revascularization, mechanical circulatory support devices, mechanical complications, and long-term results.